Hi, I'm Jared Gardner, and I'm here today with my dermatopathology fellow, Dr. Edward Fulton. And you can thank Ed for today's topic. He selected two entities that have a lot of overlapping features and often get confused with each other. They are cellular blue nevus, which is what we're looking at here, and also deep penetrating nevus. And these terms I feel get used interchangeably sometimes, as some people will call something a deep penetrating nevus that I would call a cellular blue nevus, and vice versa. And I used to think, oh, these are easy to tell apart, and actually over time I've realized that they have a lot more overlapping features than I had originally realized, and so I've become a little less dogmatic about it over time. The most important thing is that regardless of what name you give to these lesions, they are benign melanocytic lesions that look unusual and have some features that might scare you and make you think about melanoma if you're not familiar with these entities. So we're going to talk about both entities, and the most important take-home point is to recognize that these are benign things that can look unusual or atypical by normal standards, and so you don't want to overdiagnose them, okay? So I'm starting here at the deep aspect of this lesion, where you can see that this hypercellular blue nodule kind of pushing down from the dermis into the subcutis with this kind of bulging appearance. So people refer to this as the dumbbell pattern. It looks like a dumbbell like you lift weights with, and it's pushing down into the dermis. So this is a real classic example of what you're supposed to see in cellular blue nevus. And as we go up, you can see the lesion's cellular, it's multinodular in the center, kind of in some places makes long fascicles, and unfortunately it's a little bit faded at the top here, but you can see that the cellularity tends to decrease as we move up in the dermis. And if you go in for a closer look at these areas in the upper dermis, let's see if we can show it, what you'll find are areas that look actually quite like a regular conventional blue nevus, particularly in the upper dermis towards the periphery. You can see bland spindle cells intercalating with the background dermal collagen, and a lot of times cellular blue nevi are actually hypopigmented. They have less pigment than conventional blue nevi in many cases, not always, but many times. And so I think that that can be challenging for people because you're used to looking at a conventional blue nevus that has a lot of pigment. But in my experience, even hypopigmented blue nevi and hypopigmented cellular blue nevi, if you look around closely, you'll find scattered cells that have melanin in them. So let's look closely here, and even though, again, this is faded, I apologize, but it's such a good example, and there we go. There's melanin right there. So some of the cells with melanin are actually dendritic melanocytes that have melanin in their cytoplasm, and some of the melanin-laden cells are actually melanophages. It doesn't really matter which is which, but you'll see scattered melanin pigment. And this is not hemosiderin, this is melanin. Okay? I think that the areas that look like conventional blue nevus out here at the periphery are a really useful clue. When you have these areas, plus that central cellular stuff that pushes down deep into the dermis or even the subcutis, that's the best clue to me for a cellular blue nevus, is the fact that you can often find areas that look like conventional blue nevus out to the periphery. And see, let's go to low power so you can see where we are. Up here in the dermis. See, if you go out to the sides in the dermis, that's where if you go down to higher power on these areas, you'll usually find some stuff that looks like blue nevus that's less cellular, okay? And just as an aside, if you take away the pigment from a blue nevus, I feel like it looks a lot like a dermatofibroma because you get these kind of bland or sometimes plump spindle cells that are entrapping background collagen. But dermatofibromas do not usually have melanin pigment in them. They often have hemosiderin in them, but not melanin. So if you're just struggling between those two, even if you don't have immunostains, you can easily just do an iron stain to tell if the pigment's actually hemosiderin or if it's melanin. If it's melanin and you have a spindle cell lesion like this with collagen entrapment, it's much more likely that what you're dealing with is going to be a blue nevus rather than a dermatofibroma. Okay, so again, that's the kind of conventional blue component, but let's look at the cellular stuff, because this is the stuff that's going to give you some anxiety. It's hypercellular. You can see how blue it is. The cells are these kind of oval to spindle cells. Let's see if we can get them in focus here. Oval to spindle, they're kind of packed into either nodules or sheet-like areas, and they also often arrange themselves into these kind of elongated nest/fascicles. They kind of look like nests if you cut them across, and if you look at them longitudinally, like here, you can see that the cells are kind of sweeping along in fascicles. So I find that to be a useful clue. One other lesion that will also stain with melanocytic markers, just like a cellular blue nevus, that also makes this kind of arrangement into these elongated fascicles of oval to spindle cells, is clear cell sarcoma of soft tissue, also known in the past as melanoma of soft parts. And you can take higher power areas from clear cell sarcoma and from cellular blue nevus, and they sometimes can look very similar. So always keep that in mind. Clear cell sarcoma usually is deeper down and arises in the aponeurosis or tendons in the distal extremities of young adults. It will have really prominent nucleoli most of the time, and cellular blue nevi tend to not have prominent nucleoli most of the time. Now, that said, I've certainly seen some really good examples of cellular blue nevi that had prominent nucleoli. But this case is a good example of the typical pattern, kind of a fine chromatin and small punctate nucleoli, but not large kind of inclusion-like nucleoli like you would see usually in a clear cell sarcoma. If you have any doubt, you can do molecular, because clear cell sarcoma will have rearrangements usually of the EWS gene and the ATF1 gene. So even though this is cellular, it's not really that atypical. You may see some scattered in large cells that look like pleomorphism, and that's okay to see some atypia. You also oftentimes will see some mitotic activity. Again, that's usually a worrisome thing in most melanocytic lesions, but I think that it's acceptable in cellular blue nevi. Now, how many mitoses is enough? I think that there are publications out there that have discussed these things at length. If you start finding a lot of mitoses, that may be the time to use some caution and get consultation. But to see an occasional mitosis is not that concerning, in my opinion, in an otherwise classic cellular blue nevus. And another thing to think about is, compared to a normal small nevus that you might look at, and even in conventional regular nevi, we find occasional mitoses commonly if you look around hard enough. And then look at this lesion. This lesion is like 100 times bigger than most nevi we see. So it's not surprising, really, I think, to find more mitoses when you have this much more cellularity. So again, always use common sense and caution. I think this is true of all of pathology, but especially with melanocytic lesions, since missing a melanoma is such a bad thing for the patient. And always use caution. And if you're not sure, get a consult. Even as an experienced dermatopathologist, I show difficult cases, including cases of cellular blue nevi and deep penetrating nevi. I show them to my colleagues all the time as part of our normal consensus, just to help us continue to hone our skills and make sure that we're diagnostically in sync. So this is cellular blue, the bulging, pushing down into the deep dermis and subcutis, and the nuclei not very atypical, but definitely very cellular. Okay, and this will stain with a variety of melanocytic markers, like other types of nevi. And again, always looking out here at the periphery and finding areas that look like more conventional blue nevus can be a very useful clue to the diagnosis. All right, so let me show you an example of what I would call a deep penetrating nevus. And again, you may find books that show exactly the opposite of what I'm teaching, and I think that's true of all of pathology, but especially of melanocytic pathology. I guarantee you that you can find at least one thing in my lectures on YouTube that you've been taught the absolute opposite of, and that's because there's still a lot of art in what we do in dermatopathology, and there's also some areas that are fraught with controversy and people have very strong opinions about. And I've changed my mind on things, and my understanding has evolved in the 5.5 years I've been in practice, and I anticipate that I'll look at this video down the road and say, oh, I don't really agree with that anymore, because I hope that I continue to have an evolution of my understanding of melanocytic lesions and other aspects of Dermpath. So this lesion I would call a deep penetrating nevus, okay? And I think, as opposed to that bulging, rounded, deep aspect of the lesion that we see in cellular blue, deep penetrating nevus is described as having a wedge-shaped or kind of upside-down pyramid. If you kind of use your imagination and draw a line along here and a line along here, it kind of makes an upside-down pyramid pointing down towards the base of the biopsy. And as you go down, the melanocytes tend to make these kind of elongated nests that snake in between and intercalate in between the background reticulodermal collagen bundles. The other thing that really helps me in separating deep penetrating nevus from cellular blue nevus is that usually the cells in a deep penetrating nevus have more abundant cytoplasm, and the cytoplasm is kind of pink to gray in color. The nuclei tend to be kind of large and oval to round with vesicular pale chromatin and prominent nucleoli, and in fact they look a lot of times they have kind of a spitzoid cytologic features. Now, not always and not definitely, but certainly I think they oftentimes remind me kind of Spitz nevi. And some studies have shown that at least some deep penetrating nevi have molecular overlap with Spitz nevi. And I'm sure that this is something that we'll continue to have an evolved understanding of over time as we continue to do more and more molecular studies on melanocytic lesions. So, but again, the abundant cytoplasm, that's pale, pink, gray color, oval to round, big nuclei. Let me see if I can find some others that are a little clearer. That section was not very good. Here. And they're actually making like actual nests here, see? So to me, the actual nesting, the abundant cytoplasm, that makes me think more of a deep penetrating nevus than of a cellular blue nevus. And another thing is look at the background. You'll have abundant melanin pigment deposition in background melanophages, and also you'll get this kind of dusty grayish brown melanin deposition in some of the melanocytes. So that's kind of similar to what you see in blue nevi, but I feel like you get this big chunky melanophages in the background is a pretty common finding, and it's kind of patchy like this, is a common finding in deep penetrating nevus, okay? So, and again, the distinction here is not really important. Deep penetrating nevus or cellular blue nevus, whichever way you call it, you're still dealing with a benign lesion, and the key is just not calling these things melanoma, because otherwise this doesn't look like any other normal type of nevus that you would see on a conventional, the conventional nevi that we see much more often. So these are relatively uncommon compared to other types of nevi. They're more cellular, they push deep down into the dermis, they have some larger nuclei that can kind of look atypical, they can have occasional mitoses. All of those things are things that might raise warning flags for us, and that would concern us in the way we normally evaluate melanocytic lesions. But in that context of a deep penetrating nevus or cellular blue nevus, these things are okay. And as for all nevi, I'm sorry, I forgot to mention that deep penetrating nevi and sometimes cellular blue nevi also, but they both have a tendency to track along adnexal structures. And here you can see the deep penetrating nevi really hugging tight to this eccrine duct, and they'll also hug tightly around hair follicles. You can see that in both cellular blue and deep penetrating nevus, but I feel like I see it kind of more prominently usually in deep penetrating nevi. Okay, and as with all nevi, perineural involvement or wrapping of nerve by nevus cells is totally acceptable and okay for benign nevi. You can see it in benign nevi of all sorts, particularly in congenital nevi, you can see that. So just because melanocytes are around a nerve, don't call something melanoma just because of that. Obviously melanomas can involve nerves too, but I actually see perineural involvement much more often in nevi, and of course I don't put that in my report. I don't mention that as perineural invasion or anything, because that's not what it is. It's just a normal growth pattern for the nevus. Okay, and again, looking up here at the top, you can see that there are nests, actual nest formation here, and sometimes even in deep penetrating nevi, you can see nests involving the junction. In blue nevus and cellular blue nevus, you should not see junctional nests unless you have a combined nevus that has another junctional nevus component along with a blue nevus. Okay. So nests, larger cells, pale, grayish, pink cytoplasm with some fine dusty melanin, abundant, large pigmented melanophages in the background, and this kind of wedge-shaped or upside-down pyramid-shaped growth, deep penetrating nevus. And I think, again, this kind of way that the elongated nests kind of snake their way between the background dermal collagen is very helpful in recognizing deep penetrating nevus. All right, let's look at some other examples. Okay, here's a lesion that we have a shave biopsy, and it's transected right through the middle of the lesion. So we can't really see at the bottom if it's a kind of a upside down pyramid or wedge shape, or if it's got a dumbbell shape to it. So a lot of times this is what we have to deal with, the shave biopsy that's transected at the bottom in melanocytic lesions, and we don't necessarily see the entire architecture. So we have to use some of the other clues we talked about. Here we have a cellular area in the center of the lesion, and a hypocellular spindled area at the periphery. And you can see that even from low power, even though you can't see the cells, I know this is not normal dermis because look at the collagen. It's really dense and really sclerotic. This is not normal dermal collagen. This is new collagen being deposited here and thickened by this spindle cell proliferation. This is kind of the normal dermis out here to the side. For comparison, reticular dermis, you can see the spindle cells here and kind of entrapment of that peripheral collagen. Bland spindle cells. And if we hunt around, I bet we will eventually find a little bit of melanin pigment. Ah, there it is. It's quite subtle. Hopefully it'll pick up on the... Yeah, there it is. Okay, so I think it picked up on the camera here. So right in the center you can see a little bit of melanin, a little bit of melanin there, some more melanin up here. So we have those peripheral areas that look like blue nevus. The central area is hypercellular oval cells, a little bit of cytoplasm, but not quite as abundant cytoplasm as we saw in the deep penetrating nevus. And here this kind of elongated streaming fascicular appearance. So this is a cellular blue nevus. So even though we can't see the bottom and see the dumbbell shape, this is cellular blue nevus to me. This nice fascicular pattern there, I really like that for cellular blue. And again, the peripheral portion of the lesion looks like a kind of a hypopigmented form of conventional blue nevus. All right, here's a lesion on the scalp. And you can see that we can see most of the lesion. If we draw a line, it's kind of got that wedge shape, that upside down triangle. On this second piece of the biopsy, you can see it even better. Really nice wedge shape. It tends to really closely associate itself with the with the follicles. When we look closer at the cytology, the cells have like an oval to round nucleus with kind of a somewhat prominent nucleolus in some of the cells. Oops. Sorry, I'm having to drive this slide backwards. See, some of the cells have kind of a larger nucleolus. Maybe vaguely reminds you of a spitzoid cytology. Not really in this case, but a little bit maybe, if you have a good imagination. And they have abundant pale pink to gray cytoplasm and lots of large melanophages filled with melanin in the background. And you can see that the melanocytic cells here are arranged in kind of in nest-like structures. So in some areas they really trickle in between the collagen, similar to what you see in blue nevus, but here they really are forming more well-nested structures. So I feel like when I see obvious nest formation with more pale, abundant cytoplasm, that points me more towards a deep penetrating nevus than a cellular blue nevus. But like I said, I used to be kind of dogmatic and think, oh, these are easy to tell apart. And then we actually did a research study where we compared cellular blue nevus and deep penetrating nevus back to back. And my two colleagues and I looked at them together and I realized, oh, it's actually a lot harder to tell when I have to compare them and classify them. There certainly are more cases that have overlapping features than I realized. So it's nice to do research sometimes for those reasons, to help us remember the challenging aspects of what we do and to keep us humble. So this is what I would call a deep penetrating nevus. And there are other terms that sometimes have overlapping features here, like plexiform spindle cell nevus and inverted type A nevus that can have similar features here. And some people use those terms interchangeably with some of these things. I think, if I recall, plexiform spindle cell nevus is some people like to use for things that I would call deep penetrating nevus. To me, these are just terminology differences, and all of them represent different variations of benign nevi. Some people might feel very dogmatic about being precise with our classifications there. I'm a little bit more pragmatic about what matters most is recognizing benign or malignant and getting the proper care for the patient. I love to subdivide and split things for the sake of academic curiosity, but patient care to me is the very most important thing. And so again, look at that very beautiful wedge-shaped, kind of upside-down pyramid shape of the deep penetrating nevus. Okay, here's another lesion. From low power, you can see very nicely, I think, the upside down pyramid or wedge shape. You can see it's very pigmented. And it's really centered around this central hair follicle. Here's a big hair, and it's kind of wrapped around this and pushing down. And I think that that's part of what gives deep penetrating nevus this kind of wedge shape, is that it often tracks around adnexa and gets that kind of prominent peak pointing down towards the base from the wrapping around the adnexa. Just kind of my personal imagination. And this one I think is a good example of pretty nice spitzoid cytologic features. Let's get the lighting adjusted here and go closer. You got large oval round nuclei with big prominent eosinophilic nucleoli and a lot of pale pink cytoplasm. So I think when I see this nice spitzoid morphology, that really points me towards deep penetrating nevus. And I suppose you could call this a spitz nevus actually if you wanted to, and like I mentioned previously, some studies suggest that maybe at least a subset of deep penetrating nevi actually might be a variant of spitz nevus because they have the same molecular abnormalities. Up here you can even see that there are some aggregates of pink homogeneous basement membrane material. So these are caminobodies. So again, I think that you could make an argument that this is actually a spitz nevus, but architecturally from lower power, to me it has that wedge shape that I associate with deep penetrating nevus. Now, when we look at the cells in a deep penetrating nevus, you know, one thing that is often asked, what are the different cells here? Well, the big plump cells with pale cytoplasm are melanocytes, okay? So these big guys, and you can really see it clearly here because they have the big nucleoli and the large nuclei. They have pale cytoplasm, but they do often have at least a little bit of pigment, kind of fine stippled pigment in their cytoplasm. Let me see if I can show. So sometimes it's kind of little dots of pigment like this. And then other times you can have like kind of a fine, dusty pigment distributed throughout the cytoplasm of the cell. But then the really dark, very pigmented cells in the background, like these, most of these really pigmented cells are going to be background melanophages. So you get a mixture of both, and in some it can be hard to tell them apart, but usually the really dark cells like that, those are usually melanophages. The cells that have kind of a more stippled or dot-like pigment or kind of fine dusty pigment, those are the melanocytes, okay? So you get kind of two cell types here in deep penetrating nevi. Just like in blue nevi too, I think the cells look different though. These are larger and have more cytoplasm, and again, the spitzoid cytology, all those things make me favor a deep penetrating nevus, okay? And you can see again it has that nice kind of wedge-shaped appearance from lower power. All right. Now, I think this is a nice example of just how big some cellular blue nevi can get. I mean, these can be quite large lesions, and I feel like that's another thing. Deep penetrating nevi, in my experience, tend to be a bit smaller. They tend to usually be mostly in the dermis, whereas cellular blue nevi, on the other hand, often push way down into the dermis and even into the subcutis quite a bit, at least in many cases. I don't think that's a hard and fast rule. In the center here, this one, unlike some of the other cases I showed you, there's actually quite a lot of pigment here in the cellular portion. You can see the spindle cells that are hypercellular. They're arranged in these kind of elongated sweeping fascicles. There is collagen in between the fascicles. Again, that's kind of similar to the pattern that you see in clear cell sarcoma. So always keep clear cell sarcoma in mind when you're thinking about particularly these large, robust cellular blue nevi. Always think about, could it be clear cell sarcoma? And if you have any doubts, do molecular, because that's obviously a very big difference. Clear cell sarcomas usually do not have nearly as much pigment as this, but they can make melanin pigment, and like I said before, they stain almost identically to cellular blue nevus or melanoma or other melanocytic lesions. They'll stain with SOX10, S100, HMB45, MART1 or Melan-A. The one difference is that has sometimes been described on stains is that you could try using CD117 or C-KIT, which is often positive in both benign and malignant melanocytic lesions, but is usually negative, not always, but usually negative in clear cell sarcoma. But I feel like if I'm really having a hard time telling those two apart, I just send it for FISH because that's a much more definitive answer to the question. And here is another thing, and another reason that cellular blue nevi and clear cell sarcoma can have some overlap is because both lesions can have these kind of ringed, wreath-like multinucleated cells. And again, like I mentioned before, clear cell sarcoma usually has large, prominent nucleoli, and the wreath-like multinucleated tumor cells will have those nucleoli as well. Cellular blue nevus tends to not usually have prominent nucleoli. So that's kind of one clue you can use. And usually mitotic activity, although not florid usually in clear cell sarcoma, it's certainly going to be more obvious and more robust than you would see in most cases of cellular blue nevi. So here I think, again, most of the cells are pretty uniform. They're kind of oval. They look a lot like each other. They have fine chromatin. They don't look, even though it's cellular and they're kind of big cells, they don't look particularly atypical most of the time. Although you can sometimes see areas of scattered pleomorphism, and I think that's okay. And I think one of the things about melanocytic lesions is that if you jump straight to high power, you're going to have a lot of problems because you're going to find big kind of atypical, quote unquote, atypical cells in a lot of benign melanocytic lesions. So you can't just use cytologic atypia alone to decide benign versus malignant. You should always start at the lowest power and decide based on the architecture what you think the lesion most looks like, and then go into higher power to help confirm your low power architectural view. And then of course you have to take the clinical scenario, the age of the patient, things like that into account. None of those things are hard and fast in making the diagnosis, but they're all extra. I kind of view them as extra points in helping me decide. If it's a 2-year-old patient, the chance of it being a melanoma is extremely low. Not impossible, but extremely low. If it's an 85-year-old sun damaged patient and I see a huge lesion like this on the scalp, it's not that it couldn't be a cellular blue nevus, but I'm certainly going to be very, very careful and make sure I'm not missing a blue nevus-like melanoma, because some melanomas can either have areas that look a lot like blue nevus or cellular blue nevus, or you can actually have true melanoma arise out of the background of a pre-existing blue nevus. Both of those scenarios are quite rare in my experience, but they do happen occasionally. And in the few cases I've seen, usually looking around on higher power for a little bit, it became obvious very quickly that the melanomas actually had florid atypia and a lot of mitotic activity. Very, very concerning features. Didn't take very long to find those features in the cases I've seen. But admittedly, I still don't have a lot of experience because they're quite rare, and I just haven't seen that many of them yet. And like I mentioned before, when you go out to the periphery away from the cellular component, you'll find areas of smaller, kind of elongated, spindled to oval cells with real dense background collagen, very sclerotic collagen, and pigment deposition. And if you take a picture of this, I could tell you this is a blue nevus, and it looks just like a regular blue nevus, basically. And the cells here in a conventional blue nevus, the cells that you have are these kind of oval to spindle melanocytes. So as opposed to the previous case where I showed you the melanocytes of a deep penetrating nevus, a lot larger, a lot of cytoplasm, these are more oval to spindle and have relatively little cytoplasm. And then sometimes these melanocytes have very little pigment in them. Sometimes they're very darkly pigmented, but more often the darkly pigmented cells that you see in the background are actually dendritic melanophages, histiocytes that are eating up melanin pigment. So most of the darkest cells in blue nevi are usually melanophages, like I showed you in deep penetrating nevus, but they're kind of more interspersed here, and the spindled melanocytes also can have kind of a dusty pigment here. And you know, the next time you see one of these, if you do immunostains, you can see which cells are actually labeling with melanocytic markers and which ones are actually just melanophages. And that's useful educationally, I think, to learn the different components of these lesions, but I feel like in practice I don't usually use immunostains on these lesions most of the time. Occasionally, if it's a very hypopigmented lesion, I'll use SOX10 or S100 to confirm that I'm truly looking at a hypopigmented blue nevus rather than, say, a dermatofibroma or something else. So occasionally I use immunostains on them, but not that often. So again, this is a good example of just how dramatic and huge cellular blue nevi can be. And again, also a really nice example of that really prominent kind of fascicular growth, these long fascicle-like nests intervened by dense collagen that you can see in the central cellular component of cellular blue nevus. And we haven't really talked about maturation, but remember that for normal conventional nevi, acquired nevi or congenital nevi, the cells tend to get smaller and the nests tend to get smaller, and the cells trickle out into the dermis the deeper you go in the lesion. That's what we call maturation or zonation. And deep penetrating nevi and cellular blue nevi are both entities that kind of break that rule. They can be cellular and have large cells and have abundant cellularity even deep down in the lesion. So they kind of break the conventional rules about what maturation is supposed to look like. I mean, here we're down in the deep dermis, even pushing into the subcutis, and we still have quite prominent cellularity. In fact, the cellularity is often more prominent deeper in the lesion than it is at the surface of the lesion, particularly in cellular blue nevus. So this is why all these rules we use to help us decide melanoma versus nevus, they're all useful, but pretty much every one of those rules has exceptions where we can see something that we normally think of as worrisome, but we can see in benign lesions. And here is the upper aspect. This one's actually cellular in the upper aspect of the lesion too. And I guess you could argue that here the cells have more cytoplasm and kind of look a little bit more like what I showed you in deep penetrating nevus. So again, there's sometimes overlap between these lesions. So you have to kind of look at the overall pattern and make a decision. And sometimes I'll say I can't decide, and it has overlapping features of deep penetrating and cellular blue. But again, I think that for practical purposes, that probably doesn't make much difference for patient care. The most important thing is that I'm not confusing these lesions with a melanoma. Okay, so a really robust, big example of cellular blue nevus. Let's look at this case. It's a little bit faded. I think that even though it's hard to tell because the lesion looks like it fills most of the biopsy, but I get kind of a vague impression of kind of a pushing dumbbell shape down here from low power. And the other thing is I get this feeling of a cellular zone in the middle, and then the background of dense sclerotic collagen and less cellular spindle cells. So right away, even from low power, I'm already thinking about cellular blue nevus for this entity, okay? Because that cellular portion in the middle, and if you kind of imagine the cellular part looks like it kind of goes down and makes a dumbbell, kind of, if you have a good imagination. These areas here don't look like normal dermis, they're too sclerotic and have too much cellularity. And here's the other piece. You can see again this kind of bluish area in the middle is the more cellular component that kind of bulges down. The periphery has the stuff that's more sclerotic. And when we go closer, we'll see that these peripheral areas resemble blue nevus, albeit hypopigmented blue nevus. They have sclerotic collagen, hypocellular spindled to slightly ovoid cells with very little cytoplasm. And when we look around, if we turn the light up a little bit, we'll eventually find a little bit of pigment deposition in here. I guess we have to get over into the cellular areas to see it, but there's some pigment. The central cellular zones are kind of more oval in shape and a bit larger. There's one of those multinucleated cells that's actually, most of the time these are multinucleated actually melanocytes, not Teuton giant cells or histiocytes. They're actually melanocytes that are multinucleated. And they kind of have a kind of a bluish gray appearance here. These have a little bit more cytoplasm than some of the other cases I showed you, but I think they again make this kind of streaming fascicular sort of pattern here. And I think that that's helpful. And again, those peripheral areas, as you can tell, I really rely a lot on the context of what the periphery of the lesion looks like if I'm struggling to decide between deep penetrating nevus and cellular blue nevus. So I would personally regard this as a cellular blue nevus, and you can see right in the middle here, eccrine coils are entrapped within the lesion, because like I said, deep penetrating nevi tend to wrap around adnexa, but cellular blue nevus and conventional blue nevus for that matter can also entrap adnexa, and that's no problem. And I think this, let's see if this is the one. Right here you can see a small nerve invested and totally surrounded by tumor again, and even you can see the tumor tracking out away from the main mass around little nerves like this. Totally fine. Go and look at a nice obvious benign congenital nevus, not a blue nevus. Look at congenital nevi, and you'll often see nerves that are wrapped around by spindled melanocytes, and it's the same kind of pattern that we see here in cellular blue nevus, and also sometimes deep penetrating nevi. Don't be worried about this. This by itself is not at all a feature of malignancy, in my opinion, because I see this very often in benign melanocytic lesions. So I would regard this as, oh, here's another one. Right there, there's the nerve, and here are the spindle melanocytes from the cellular blue nevus wrapping around that nerve. Totally normal. Personally, I don't even mention that in my report, unless someone sent it as a consultation and asked, oh, is this perineural invasion? And then I say, no, it's okay to see this. Let's see if I can get this slide to show up. And here's this is the two shave sign. Here they did one shave biopsy, which transected the lesion. Oops. And then what happened is the dermatologist recognized after they shaved it that there was still a dark black spot at the bottom of the shave site where they did. And so they do a second shave to get and scoop underneath the whole lesion. So I see this a lot, and if you're a dermatologist watching this, I usually recognize this is what's happening, but it's really helpful if you put it on their double shave or saw dark spot, shave deeper, 2 pieces in the bottle, something to let us know that that's exactly what's going on here. But from experience, I can tell right away that that's what's happened. This is where the original shave was. They saw the dark spot at the bottom, and they went back and did a second shave underneath it. And so that's a good clue. And I feel like I often see this particularly in the setting of cellular blue nevi and deep penetrating nevi, because both of them tend to go deeper down, and they both tend to have a lot of pigment. So the dermatologist right away recognizes, oh, there's more pigment down deeper. And look, this is already a pretty deep shave. They did a nice deep shave, and yet still the pigment was down below this. Melanoma, of course, could do that too, but I see it much more often in this setting. Okay. And so now what are we going to do? If we only had this and say we didn't have that deeper shave, we can't really tell for sure if it's dumbbell shaped or wedge shaped. But look, we can see that there are melanocytes with a bunch of cytoplasm, and we can tell because of how pale they are. And they're kind of weaving in between the pink collagen bundles. And you can see really dark, really abundant pigment in individual clusters of melanophages kind of scattered throughout here. So I think that even from low power, I'm already thinking about this being a deep penetrating nevus, probably more likely than, sorry, the slide's kind of at an angle. I'm going to have to do it crooked or it'll fall into the stage. Okay. And then when we look closer, the cells have abundant pale pink to gray cytoplasm, and sometimes they will have a little bit of dusty pigment in them. Like here, you can see just a touch of pigment. These are melanocytes, and they have a little bit of fine pigment in the cytoplasm, but the really dark, large, clumpy pigment in the background, most of those are going to be melanophages. And again, the abundant pigment here, and the way that these kind of tumor cells interweave in between the collagen, this fits to me better for a deep penetrating nevus. And also, if I see nest formation, that's another feature that makes me think of deep penetrating rather than cellular blue. All right, so let's kind of finish by looking at, I guess, a more controversial case. So what are we going to call this lesion? Again, it's kind of faded, I apologize. And sometimes I found that looking back at my recuts from fellowship or early in practice, looking back at them later, I find that what I had them label as in my collection is a little different than I feel about them now. And that's okay. That's part of, I think, developing over time and changing your views. This is a lesion that has a you can't even fit it. I'm on 2x magnification and I can't even show the whole slide, but it really has this pushing dumbbell border down at the deep aspect. Oh, like right here, you can see this rounded dumbbell shape going into the subcutis. Right away, that should make us think of cellular blue nevus. At higher power, some areas look kind of like the cytology of cellular blue nevus. But some of them are kind of more plump and have more cytoplasm, kind of like a deep penetrating nevus. So these are ones that I kind of, might struggle with. So we could go up to the top and to the periphery. Well, I don't really see in the background here, I don't really see much of that sclerotic, conventional blue nevus looking component like I saw in the other cases. So that's hard. And if I go over to this side, actually, oh wait, different piece. What I see here is actually, look, conventional nevus, maybe congenital nevus even. I see nests of obvious, conventional looking epithelioid melanocytes trickling in between the collagen, maturing as they go deeper. So I think this is a combined nevus. And when you have a nevus that you're having a hard time classifying, always think of combined nevi. So here I think is either a congenital or a conventional acquired nevus component. And over here probably is a cellular blue nevus. There may even be some aspect of deep penetrating nevus, and they're all mingled together. And I think that, again, this is the challenge that, and see there's more of the conventional nevus up there. So if you're feeling like you're having a hard time classifying, it may just be that there's more than one nevus component present. So keep that in mind. I hope that this has been helpful for you. Thanks for watching. Please click like and subscribe if you haven't, and also leave your comments or questions down below. Thanks.